Now we continue with another type of adaptive process, in which adaptation consists in replacement, in some situation reversible, sometimes not reversible, but replacement of a type of differentiated cell in another type of differentiated cell, much more resistant for the new created conditions in the affected tissue or organ. We have more than one type of metaplasia, but we'll discuss only about epithelial metaplasia and some ideas about mesenchymal metaplasia, not about the other types also possible, but which are much rare. Epithelial metaplasia consists in change of one type of epithelia with another type. For example, the unistratified epithelia being replaced with squamous stratified epithelia, or by contrary, the squamous stratified epithelia being replaced with an abnormal unistratified glandular epithelia. And we'll see each of examples separately. For example, the epithelial metaplasia with replacement of the unistratified with squamous cell metaplasia appear by far the most frequently in the large bronchial tract. Inside the lung, but in the large bronchia, so nearby the hilum, in heavy smokers which are smoking for very long period of time. The otherwise normal unistratified respiratory epithelia with ciliary edges are not resistant enough to the toxic substances coming with smoking. These substances are slowly but surely killing these non-resistant cells, they being regenerated continuously for a period of time. But if it's the smoking habit, it's for a long period of time. After years of smoking, in a certain moment, these cells, not resistant enough, will be replaced with squamous epithelial cells, which are normally present on the surface of the skin, for example, and are much more resistant for chemical irritation, chemical aggressions. So this replacement is a chronic process appearing in time and is happening only in the large bronchia, not everywhere in the respiratory tract. The same thing is happening in the excretory ducts of the salivary gland, pancreas, bile ducts. If stones, lithiasis, are present inside the ducts and mechanically, with friction, is destroying this unistratified epithelia covering normally these ducts of the glands. The result, again in time, will be a replacement of these unistratified glandular cells with a much more resistant for friction squamous epithelial cells. It is considered to be a reversible process, but there are some other authors which are saying that once produced, such a metaplasia is not reversible anymore. Even by contrary, they are all of these example of pre-neoplastic lesion, meaning that from metaplastic mucosa of the respiratory tract, for example, again after a while, because it's necessarily again even more time, cancer can arise. And we'll see, in fact, the fact that the pulmonary cancer of the smokers are not originating from the unistratified epithelia of the bronchial tract. They are called bronchopulmonary cancer because they are originating from the epithelia of the bronchial tract, but they are not originating from the unistratified. They are originated from the squamous stratified epithelia, and they are, for this reason, in fact, squamous cell carcinomas, and are, for this reason, much more aggressive in behavior than the other cancer, also possible to appear in the lungs from the unistratified epithelia, which are called adenocarcinoma, and who is not related with smoking. For this reason, much rarer. In the glands of these salivary glands, pancreas, and so squamous metaplasia, it's in theory possible also to induce malignization, but about this possibility it's still a debate. It's not very clear. Very, very few cases were described, and probably not for this reason appearing. Here it's an image, microscopic image for a unistratified, pseudostratified, more exactly respiratory epithelia, normally present in large bronchial tracts and in the smaller one, but only here it's appearing the process of metaplasia being replaced with an obviously stratified epithelia squamous, but not with keratin on surface. The other type of epithelial metaplasia, in which this time the squamous, resistant otherwise for chemicals, squamous epithelia is replaced with a unistratified one. It's happening almost only at the level of the lower segment of the esophagus, lower third of the esophagus, in which normally we have a squamous epithelia covering the esophagus. But at this level of this lower segment, reflux of gastric content, it's frequent and affect chemically this squamous cell mucosa. When the reflux is with acid from the stomach, yes, the squamous epithelia is much more resistant than many other epithelia for different chemical substances. But for acid, we only have one and only one epithelia in our body which is resistant for acid, and this is the gastric mucosa. Gastric mucosa being specialized in producing a very unique mucus which is impenetrable for acid. For this reason, stomach has this mucosa because it has acid inside, which is resistant for acid, not in the same grade, the same level, the resistance of the squamous epithelia of the esophagus. For this reason, if the gastric acid reflux is long in duration, then it's replaced the stratified mucosa with a gastric type mucosa to adapt to the situation of chronic long duration acid reflux in the esophagus. Differently, somehow similar but also differently, it's happening if the reflux from the stomach in the esophagus contain bile. Bile is a very caustic substance made to dissolve the lipids mostly, including the lipids of the membranes of the cells in the process of digestion. The squamous epithelia is resisting for the presence of bile for a while. But if it's again long in duration, will be replaced with intestinal type of mucosa, because the intestinal type of mucosa is the only type of mucosa which is normally adapted to the constant presence of bile inside. So has a mucus different from the gastric mucosa, mucus which is resistant to bile. So in this context of bile reflux in the esophagus, the replacement will be with intestinal mucosa, but again a unistratified one. In both situations, from this metaplasia, esophageal cancer appear frequently, much more frequently than without previous metaplasia. And this process of metaplasia of the lower esophagus segment is called Barrett esophagus. And Barrett esophagus by itself, in both situations with gastric metaplasia or intestinal metaplasia, because both situations are called Barrett esophagus, in both situations are pre-malignant conditions. With the risk of appearance of a cancer on this background of Barrett esophagus, much higher for intestinal type of metaplasia than from gastric type, but possible in both. And here is such an image of whitish squamous normal esophageal mucosa being replaced with a reddish, thinner mucosa in the lower part, which is such a metaplasia seen macroscopically. At endoscopic or macroscopic examination, we can see this replacement. We are called this situation as Barrett esophagus, but we cannot say if the metaplasia is with gastric or intestinal type of mucosa. This being possible be seen only at microscopic level. For this reason, both situations are called in the same way, Barrett esophagus, and without making any difference between them, despite the fact that there are differences. One is produced by acid, the other by bile. Both of them are risk for cancer, but the intestinal type with higher risk than the gastric type. And here we can see the squamous epithelia, remains of it, these small islands here, being replaced with unistratified epithelia with goblet cells, which is characteristic for the intestinal segment of the mucosa, even with glands in deeper submucosa. So this is a Barrett esophagus with intestinal metaplasia, with very high risk. On this image, this time again, the squamous normal mucosa of the esophagus being replaced with a unistratified, but without goblet cells, which is characteristic for stomach to have such type of mucosa. So here we have a gastric metaplasia, Barrett esophagus, with lower risk present, but lower risk of cancer than the one. In the connective tissue, which is a mesenchymal tissue, meaning by mesenchymal tissues is all the tissues which are not epithelial. So at this level, because of stem cells mostly, undifferentiated stem cells, replacement of one type of tissue with another type of mesenchymal tissue is possible anywhere. By far the most frequent situation and most important in human physiology and pathology is the process of healing of a bone fracture. Here, the bone, first of all, in the fracture process means that we have an interruption, not only of the bone itself, but also of the vessels inside the bone. As a result, a hemorrhage will develop here between the endings of the fracture. This hemorrhage is with blood which will almost instantly coagulate. The result of this coagulation will appearance of a solid mass of fibrin. It's the first stage for the healing of the fracture, this clot of fibrin, in fact, present between the endings of a fracture, and it's called fibrinous callus because contain fibrin. In evolution, this fibrinous callus evolved like the thrombus itself, which is also a fibrinous mass, but inside a vessel. This is why it's thrombus called. Here it's not inside a vessel, it's between the edges of the fractured bone. The evolution, it's as we already discussed about, with appearance of neoformation capillary in a granulation tissue, and at the end of around 1 month of evolution being transformed in a scar, the scar being formed of fibrous tissue. For this reason, at 1 month distance, or even less than 1 month, we have a fibrous callus connecting the edges of the fractured bone. On this background of a presence of a fibrous tissue, from the nearby bone, stem cells can invade in the previous present capillary of neoformation with cells which will evolve in their differentiation process in even cartilage cells, cartilaginous cells, or bone cells, replacing in time the fibrous callus with a cartilage tissue, or later with a bone tissue. When the cartilage is formed, it's not good enough. The resistance of cartilage is not good enough, and it's still called callus, cartilaginous callus. But after all, even this cartilage will be transformed by ossification in the process of bone metaplasia in a bone tissue, replacing and healing in this way the fracture itself. It's taking about a month and a half to make this process of healing possible. What is to discuss supplementary is the fact that the bone, the fracture itself, should be immobilized, because otherwise the fibrinous callus and the fibrous callus is formed. But without immobilization of the bone, being movements present here, the fibrous tissue will evolve in a cartilage, but the cartilage is not resistant to this movement, even if they are small, and will crack. The result of crackment will be a space here covered by cartilage on one side and by cartilage on the other side. And this space is called a pseudo-articulation and remain like that forever. In fact, it's a new articulation appearing in what is called bad healing of a bone fracture. If it is correctly immobilized without any movement at all, the transformation of fibrous callus in bone is direct without intermediate of a cartilage, and is quite rapidly. If small movements are present, the cartilage callus appearing as an intermedia will heal with bone later in evolution, but it's take longer. So this is why it's very important not only to make an immobilization, but to make one of a good quality for rapid healing. After all, with immobilization, just immobilization, healing is appearing, but it's taking much longer time. This is why in our days now, most of, at least for the big bones, long bones, fractures, they are immobilized by surgery. And after that, with external immobilization. So to make this immobilization as strong as possible to favorize the direct healing and rapid healing. After that, the surgical immobilization with nails, with different metallic plaques, put it here in scrubs and so and so. It's at the end they will be removed, and after removal a good quality bone will be present beneath it. Here is such an image of a fracture in a bone with cortical plate with trabecular bone inside, and the fracture being healed inside with fibrin, and already fibrous tissue starting to develop, cartilaginous tissue is present in this intermedia between edges. Okay, with this slide we finished with the adaptive processes, from which metaplasia was the last one. And we'll start to see what is happening when cells are injured much intensely. And as a result of this, if the injury, despite the fact that it's intense, is short, it will induce reversible modifications in the cell which will survive. Or if it's longer, the same stimulus, the same injury, if it's longer in duration, will induce irreversible injuries which will generate cell death. These are the reversible lesions. The hydropic swelling, meaning accumulation of droplets of water in the cytoplasma of cells, and the fatty change or steatosis, in which we have accumulation of droplets of fat in the cytoplasma of the affected cells. So in both situations we have droplets, one with water, the other with fat. Both of them in hematoxylin eosin, in which the fat is dissolved, in fact, the process of preparation of the slides. In both situations having in hematoxylin eosin, I repeat, the aspect of vacuola or small holes cavity present in the cytoplasma of the affected cells. Otherwise, the cells still having a nuclei, still having external membranes, so still being alive, but with these intracytoplasmatic droplets being present, which is the sign for an injury at the beginning, which will disappear if the injury is short, or by contrary will kill the cell by accumulation of this substance inside, will kill the cells if it's in. Here we can see the graphic of the idea of reversible cell injury if the duration is short, and irreversible if it's the duration longer. Which are these injuries? A lot of them. Very frequent decrease in oxygen availability for the affected cells, or oxygen deprivation. But physical agents like radiation, heat, chemical agents and drugs, a lot of them, are inducing the same. Infectious agents, especially microbes producing toxins, are generating the same thing. Immunologic reaction, meaning antigen-antibody reactions, can induce the same thing. Genetic defects and nutritional imbalances, all of them can induce such reversible initially or irreversible cell injury. We'll start with the hydropic swelling, meaning accumulation of droplets of water inside. We should just remember the fact that our cells are energized in their metabolism activity by the ATP, adenosine triphosphate protein, which is a sort of battery for the cell in which energy produced in the mitochondria, burning the oxygen in the process of aerobic respiration. This energy is produced and is accumulating in the cell. And after that, it's used in all kinds of metabolic activities of the cell, maintaining the cell alive in this way. One of the most important usage for ATP is this pump of sodium-potassium dependent pump, external or membranal pump. This pump is maintaining a gradient for this ionic substance, sodium and potassium, which is normally very low outside in the interstitial fluid, the potassium, and very high in concentration inside. By contrary, sodium is very low inside and very high outside in the interstitial fluid and in the blood, also in the serum. This maintenance of this gradient, it's very important for the cell to live. But when the oxygen is low in availability, the cell is changing the aerobic respiration to anaerobic respiration. This means that mitochondria is still functioning, but activating the cycle of Krebs, which don't need oxygen to produce energy. But the produce energy, the quantity, it's much smaller. So the adenosine triphosphate protein will be less available for the cell. And one of the first to suffer from this less available will be the pump, this pump itself. Being less energetic, the pump, part from the high sodium from outside will enter back in the cell, and part of the potassium, very high inside, will go out. You maybe know, you maybe heard, maybe not. But in the process of euthanasia, when we are killing at demand somebody, animal or human, the way in which it's done is by placing a perfusion with potassium. High level of potassium in the blood, which should be very low, and maintained by all cells by function of their pumps, maintain low. If we have high level of potassium in the circulation, death is a death consequence appear. It's painful, and for this reason they are sedating and with painkiller before to not feel anything at all in this process of euthanasia. So the cell is not dead yet, but the power of the pump is reduced. A backflux of sodium and calcium will appear, and this is it's done with water coming together. So sodium and calcium, it's coming back in the cell, but dissolved in water. So a higher quantity of water it's accumulating in the cell. And it's not accumulating anywhere, but it's accumulating in the mitochondria itself, will become enlarged and ballooned in a vacuola, more exactly transformed. And after mitochondria is affected, reticulum endoplasmatic structure it's also enlarged with accumulation of water inside and became other vacuolar spaces inside. Close to the nuclei, this one is it's at a distance, but the difference is it's seen only in electronic microscopy. So in this way, in a context of anaerobic respiration, if it's short in duration, because if it's long, obviously the cell is dying because too much potassium is going out, too much sodium and water is coming inside, breaking the cell. So big became this vacuolar accumulation of water that it's breaking the membranes of the mitochondria, of the reticular, of the reticulum, and at the end of the cell itself. The affected organs are larger because they are accumulating water inside and paler in color. The most affected, seen macroscopically, are the liver, the kidney, and the heart by this process. At microscopic level, we have 3 levels of severity of hydropic swelling, meaning initially, normally we don't see in optic microscopy the mitochondria. When they became visible because they start to grow in size by accumulation of water, we can see this as a granular aspect of the cytoplasma of the affected cells, not yet vacuola being present. So granular dystrophy, it's called this first stage. It's very initial, it's very at the beginning, obviously extremely easy to be reversed if the availability of oxygen or the toxic aggressivity, whatever, it's not anymore present. If it's more longer, a little bit in duration, this granular dystrophy is changed in vacuolar dystrophy, in which clear vacuolas with water inside will be seen at the level of optic microscopy, ending in so large and large vacuolar spaces that it's called ballooning dystrophy at the most severe part of the dystrophy. In this, almost the entire cytoplasma is replaced with a ballooning vacuolar space with water inside, but still having the nuclei present and the external membrane of the cell being still present. So the cell is still alive. It's very close from dying when the membrane are ruptured. So it's very close to dying for these cells affected in the ballooning dystrophy, but they are not yet. If now the cause is disappearing, it's still reversible, so will disappear slowly but surely, regaining the normal structure, the affected tissue or cells. And here is the general look for liver, normal, and with hydropic dystrophy, meaning larger and paler in color. And this is how it looks, these vacuolar spaces in the hepatocytes. So it's a vacuolar dystrophy in these cells, and in these others, even for an untrained eye like yours, you can see that the cytoplasma is very finely granular, but is granular. So we have in this image, one of my images otherwise, the presence of both granular and vacuolar dystrophy, so initial severity and middle intensity severity of from the same case but in another part of the liver, having vacuolar dystrophy, so medium intensity, with hydropic dystrophy, with very enlarged ballooning dystrophy here, which is almost resulting in breakage. Here this cell is already died. The nuclei is compressed, the cytoplasma membrane is breaked by the ballooning dystrophy. Not yet in this one, already breaked here, already breaked here. So some of them are already dead. Still no problem if only a very few are dying in this process if the cause is removed, because they can be regenerated easily by the nearby cells after coming. So they can return to normal or to die by necrosis. In fatty dystrophy, it's very much the same thing, but this time by accumulation of, in the process of Krebs cycle activation in anaerobic respiration or under the effect of different toxics, chemicals like alcohol, also other carbon tetrachloride, it's a very potent inducer for fatty dystrophy, used in fact for animal experiment of fatty dystrophy. Research. So we can have a lot of causes for it in which we have the same accumulation of initially very small droplets of lipid, initially seen only in electronic microscopy, and after that they becoming larger and larger as vacuolar spaces seen in hematoxylin eosin again. The only way to make the difference between the hydropic and this fatty dystrophy is to make a different stain, not hematoxylin eosin. This different stain, it's a stain for lipids with Scharlach-Roth or tetraoxide of osmium and others such special stains for lipids. Made, and here is the problem coming, absolutely necessarily being made on frozen section and not in normally fixed in paraffin tissue, because by fixation in paraffin the lipids are dissolved. Fortunately, it's not necessarily, because the trained eyes of a pathologist can easily make the difference between this process in hematoxylin eosin, despite the fact that they are very much alike, but not entirely. Macroscopically, the affected organ, again, liver most frequently, but also possible for kidney and heart, are larger, softer in consistency, and yellow in color. Especially for the liver, it's called steatosis, this yellow color of it, also called as field goose liver. This old name, it's a comparison, in fact, with the liver of goose used for making very good, tasty food from it if it's already filled with fat inside. And this was possible to be obtained by giving to the goose before sacrification alcohol with force, just filling their mouth with alcohol and forcing them to eat alcohol, obviously with the drug consequence, but also with very rapid liver dystrophy in them, which after this process are much better for the cooking, especially in France. It's done like that, even in our country, but mostly in the past, not as much now. In the heart, we'll see the image and I will explain you there. In the kidney again. So this is the steatotic liver. This is how it looks. The enlarged and soft in consistency, yellow in color liver of an alcoholic. Not only alcohol is producing such a thing, also other toxics, a lot of them, chemicals from use for anesthesia, for example, for other purposes. A lot of other chemicals can induce the same thing, but alcohol is the most frequent cause for liver steatosis. Obesity is the other one. It's called alcoholic steatohepatitis for those in which steatosis is related with alcohol, and non-alcoholic steatohepatitis in the context of obesity appearing. They are absolutely alike macro and microscopically, but with different metabolic mechanism. Here is what is called the tiger-striped myocardium, in which we can see the normal brown color of the normal myocardial fiber alternating with yellowish area, and they are yellowish because they are suffering from fatty dystrophy. And this is happening in diphtheria and is in fact a name given for diphtheric myocarditis. In this myocarditis, the diphtheria, the bacillum, diphtheric bacillum, it's in the pharynx and remain there. It's not migrating and it's not infecting the heart at all. It's still in the pharynx, giving there in the pharynx some lesions. We'll see much later what exactly. But giving there in the pharynx local lesions, but which diphtheria bacil, it's producing exotoxin, which is liberated outside from the microbe, is absorbed in circulation, and have a particularly toxic effect on myocardial muscle, having a toxic effect on other tissues too, but particularly intense for the myocardial muscle, and this is the diphtheric myocarditis, the effect of this toxicity. And this toxicity consists in fatty dystrophy, more exactly. And this is why this appearance, described in all literature, including in Romania, as tiger-spreaded myocardium, or in Romanian, inima and blana de tigru. At the microscopic level, in hematoxylin eosin, as I said, we can see vacuolar spaces, but with spatial stains we can see the presence of fat in the vacuolars. Very, very rarely being done, only when it's not very clear what is there. For example, here the alcoholic liver with a lot of very large vacuolar spaces everywhere in almost all hepatocytes, in hematoxylin eosin, or here in spatial stain for lipids. Something extremely, but least obvious for this. Here it's heart tissue again, myocardial fibers, in which with spatial stain we can see a lot of very small vacuolar spaces not very obvious in hematoxylineosin stain, being stained with Scharlach-Rot for lipid dystrophy. This particular image is taken from a patient who died intoxicated with mushrooms, more exactly with Amanita phalloides mushroom, which has this extremely toxic effect on a lot of tissue, especially on liver, but also on the heart, the level of the kidney, where from the same patient, the same coloration for lipids made to see the very small otherwise, but a lot of them, lipid vacuolar accumulation in the tubular epithelia of the kidney. Again, it's reversible if it's short in duration, and it's generating necrosis if it's longer in duration, necrosis of the cells. And now to discuss a few things about how the cells can die. In fact, they can die by two different mechanisms. In both situations, the result being the same, the loss of the affected cell or cells in large number. But in one process called necrosis, the organoids, intracytoplasmatic organoids, is accumulating inside water or lipids, enlarging. And for this reason, the cell is enlarged, it's swelled more exactly. And by this accumulation larger and larger and larger, initially the internal organoids, especially the mitochondria and the endoplasmic reticulum, will break their membranes. And at the end, the external membrane of the cell will also be breaked. The nuclei membrane will also be breaked, and the entire cell will be dissolved by this breaking process of all membranes inside the cells and at the edges of the cell itself. So it's a breaking process here by accumulation of water or fat. And the result will be extravasation in the interstitium of proteins normally present in the cytoplasm. And these proteins, being liberated outside in the interstitium fluid, will attract polymorphonuclear cells, especially, which are inflammatory cells, which are triggered to come here to phagocytate the necrotic, the dead cell, and this way to heal the lesion. So necrosis, it's by swelling initially, enlargement of the affected cells, and triggering at the end a local inflammation, which has this, at least, particular purpose to come to phagocytate, to digest, to liberate the place by the necrotic proteins resulting from the necrosis. And also, if the etiologic agent is a microbe or something like this, to eat it as well, the cause for the entire process. By contrary, apoptosis, it's happening vice versa. The cells affected by apoptosis are in fact producing suicide, and is a genetically triggered mechanism for different reasons, but it's genetically. So the etiology is not somewhere outside, it's inside the cell, and consists in activation of specific enzymes which are breaking the DNA, is breaking of the nuclei, it's breaking the internal structures. And because of this process of autodigestion, more exactly, of the affected cells by apoptosis, we assist to a shrinkage, not dilatation of the affected cells. And at the end of this shrinkage, small fragments of the former cells, meaning very small membranes covering a content inside, in which it's possible to have fragments of mitochondria, fragments of reticulum, plasmatic and reticulum, fragments of the nuclei, including all these small, very small fragments called apoptotic bodies will be liberated outside, but not the content of the cell is not liberated in the interstitium. All the content of the cell is still covered with a membrane, so isolated from the interstitial fluid. And for this reason, it's not triggering inflammation. So polymorphonuclear cells will not come, but still the local phagocytes, because macrophages are present anywhere in any tissue, these local macrophages will phagocytate this apoptotic body, and in this way will remove the rests remaining after apoptosis, which, repeat, is internally genetically triggered process, also called suicidal process. Here we have a synthesis of what I said. In necrosis, cells are enlarged by swelling, with pycnosis, meaning diminution, and at the end karyolysis of the nuclei. The membrane, all membranes inside and outside are disrupted, and leak out the content, and inflammation is triggered in the area of necrosis. By apoptosis, we don't have inflammation, membranes are intact. It's fragmentation in smaller fragments of the cells called apoptotic bodies. Now we'll continue to see some patterns, particular patterns of necrosis. By far the most frequent one, it's what is called coagulative necrosis, or a necrosis of coagulation. It is by far the most frequent because it's the type or pattern of necrosis appearing in infarctions, in most infarctions like renal, splenic, myocardial infarctions. The result of this coagulation is a dead tissue, but with firm texture because it's coagulated protein. But who already we saw when we discuss about infarction, it's triggering at the edges the appearance of polymorphonuclear cells, which will start to transform the coagulated protein of infarction in a granulation tissue, and after that in a scar in the process of healing. And here is such an image of a white, triangular in shape renal infarction. At microscopic level, it's amorphous acellular eosinophilic, meaning red, but still, because of a coagulation, seeing as ghosts, the former structures, the glomerular and the tubular structure, are possible to be seen for a period of time at least, until the polymorphonuclear cells trigger to come in the area will transform the entire thing in a grand. Liquefactive necrosis is another pattern, this time characterized by liquefaction of the necrotic tissue, which is transformed in this way in a gelatinous, viscous liquid mass. It's especially the case for necrosis appearing in focal bacterial or fungal infections, because microbes especially are producing enzymes which are digesting these necrotic proteins resulting from necrosis, and is transforming this necrotic cell in a liquid which is very, very rich in polymorphonuclear cells attracted at the site by the necrosis itself and by the presence of microbes too. And this mixture of a liquid with necrosis and polymorphonuclear cells is called pus. In brain infarction, it's the same process of liquefative necrosis, but this time the liquefaction is the result of attraction of water in a necrotic tissue where we have a lot of lipids, the myelin cover of the nervous tracts being the cause of this process of. And here we can see such a liquefative necrosis again, so cerebral infarction macroscopically and microscopically, resulting in disruption of the necrotic cells by accumulation of water inside. Gangrene is another particular type of necrosis. In fact, it's the equivalent of an infarction, but happening in tissues which are in connection, in contact, direct contact with air. It's happening, and it is described mostly at the level of the limbs, but possible in other locations too, like inside the lungs, for example, where also we can have direct contact between air and necrosis. Dry gangrene, it's one type of gangrene because we have more than one type. And the dry gangrene is the equivalent of coagulative necrosis infarction, more exactly, resulting from ischemia, meaning complete obliteration of an artery, a terminal artery usually on the extremity of the limbs, atherosclerosis, thromboangiitis, or arterial spasma being the cause for it. As a result, a necrosis will start to develop, and what is characteristic for the dry gangrene is the fact that necrosis starts from the very distal side from the obliterated vessel. So the most distant will die first. But progressing after that, slowly but surely, until the entire irrigated previously by the occluded artery zone is dying. And at the end, the dead zone will be very well delimited, like any infarction otherwise, from the non-dead area, at the exact limit where the obstruction of the artery appeared. It's called line of self-amputation, because if it's not treated with amputation, self-amputation will appear in time, if not none other complication appear in the meantime. Initially, the skin, affected skin of the limb, the extremity, it's pale because it's without blood. It's cold because it's without blood again, and dried. And it's dry because it's losing by dehydration in contact with external air the humidity inside the tissue, the necrotic tissue, will very rapidly lose the hair, and very soon will turn in black, the color of the affected area. And this is the result of small hemorrhages appearing inside the necrotic area, with a liberation of hemosiderin, which also will be degraded in a black pigment. So in evolution, self-amputation, it's appeared if it's not infected, the necrotic zone, but if it's infected with microbes from outside, and usually very easily such a thing is happening, the initially dry gangrene will be transformed in a from dry to wet gangrene, and we'll see it. For the moment, it's a very well delimited segment at the affected edges of the limbs, more or less extended, black, well delimited. Here it's another such an image. And if it's over-infected with microbes, these microbes will start the process of pus transformation of the necrotic cell, meaning with enzymes will liquefy the necrotic tissue. And for this reason it's called wet, because it's a gangrene transformed in a liquid. It's affecting also other segments, not only the limbs, but also internal organ in contact with air, like intestinal wall, appendix, gallbladder, and lungs. Here, the process of overinfection, it's impossible to be controlled. So any gangrene dry initially will become wet in very short time. At the level of the limbs, being at the surface, with antiseptic local treatment, we can eventually prolong the time of the dry gangrene presence. But sooner or later, it is infected and will be transformed too. For this reason, to avoid such transformation, dry gangrenes should be amputated and not let them spontaneously evolve to self-amputation. It is possible, this process, but it's not desirable to evolve in this way. So we make the amputation when a dry gangrene is seen, to avoid this overinfection. Because after infection, it's not only transformed in a wet gangrene, but also the infection will extend in the otherwise healthy tissue nearby, affecting this tissue too. And amputation necessarily now, to avoid septicemia, will involve much larger quantity of tissue than initially. So initially, for the dry gangrene, we can limit our amputation for only the segment, necrotic segment. Now it's necessary to remove surgically by amputation a much larger segment. This is why it's preferable to do it before overinfection. As a clinical sign, this process of wet transformation in pus starts randomly on the surface of a previously already dry gangrene, not starting from the most distal side, but anywhere on the surface. And it's transforming the initially gray-black area in a reddish and greenish, bad-smelling, imprecisely delimited area, which is expanding rapidly in the neighborhood previously healthy tissue. And this is how it looks. Initially, it was a dry gangrene, but over-infected being it extended, generating necrosis, but wet necrosis this time, with microbe over-infection in a much larger segment, and the amputation was necessarily not limiting to the initially dry gangrene zone, but much more extensive, and losing a large part of the limb in the process. Here it's another such an image. Gas gangrene, it's another type, very similar with the wet one, but this time the microbes involved in overinfection are anaerobic ones. Clostridium perfringens being the main etiology, in which microbes not only transform in a liquefaction process, the necrosis, previous necrosis, but also generate bubbles of gas accumulating beneath the surface of the necrotic skin, and these bubbles are dissecting very rapidly the tissue, favoring the extension of the infection even more and even more rapidly than in the ordinary wet gangrene. For this reason, they need to be amputated. This dry or even wet gangrene as soon as possible, and not let them to become gas gangrene, because the even penetration in the blood of these microbes and transforming in a septicemia is very, very rapid. And gas gangrene, for this reason, it's frequently a cause of death, or being possible to do anything for them. Here it's such an image. Another type of necrosis, somehow similar with the gangrene, it's what is called pressure or decubitus ulcer. It's appearing in long duration bedridden patients, paralyzed mostly, or suffering from other terminally ill patients, which put them in bed for a long period of time in the same position. Here, because of compression between the hard skeletal tissue and the bed itself, because of the compression between these two, the capillaries are closed in the soft tissue, and being closed, an ischemic necrosis appear at this level, generating this kind of decubitus ulcer in the particular areas in which the body is in direct contact with the bed itself. Staying on back, usually, these patients, this decubitus ulcer will appear in the occipital region, the shoulders, the sacral region, the buttock, ankles, or elbows. These are the most frequent locations for the pressure decubitus ulcer, but it's possible in any other location to appear. Here we have such a decubitus ulcer appearing in a case, one of mine. It's an old case, who died with hydrocephalia. Being with hydrocephalia advanced, the otherwise child was paralyzed and stay in bed for a very long period of time in the same position. It's not normal to be like that. Normally, such a patient, the paralyzed one, should be mobilized permanently at least once in the hour, to be put in another position to avoid such necrosis to appear. But to doing such a thing, you need a lot of work from nurses, which are, at least in our country, not enough number. They are carrying about a lot of patients, and they are not dedicated, one nurse or physiotherapist. It's even better than an ordinary nurse for one patient who need to be mobilized continuously. For this reason, in our hospitals, such escarides, called in Romanian language, or decubitus ulcers, are unfortunately quite frequent, and they are always the result of bad management of the patient. Unfortunately, it's a malpractice, but very few persons know about. fortunately for us. Here is the decubitus ulcer, extremely large, severe, developed in that particular patient that we discussed about it having cachexia. It was as I said, 17-year-old boy with ulcerative colitis, with a lot of surgery, removing almost entirely his bowel, developing cachexia, and with a very severe malnutrition state. He was also without power, remaining power to move. He didn't have energy. He was not paralyzed, but he didn't have the energy to even move anymore, and staying a lot on his back or on the lateral side. He developed these lesions, not being well enough managed by the hospital. And he died at the end because of cachexia, but also because of infections coming from this decubitus ulcer. Another type of particular type of necrosis is called caseous necrosis. We will not develop very much the idea now, because we will develop the idea when we learn about tuberculosis, because it's a very specific type of necrosis appearing only in tuberculosis. It macroscopically looks like a cheese, being white, and we'll see in the next image how it looks, and we'll develop the idea when we'll develop the idea of tuberculosis itself. Fat necrosis, it's another very particular type of necrosis. The necrosis of fat it is like in the case of a brain, very rich in fat substance. It's a liquefaction type of necrosis. It is seen in traumatic fat necrosis, like in the brain, with a liquefaction of traumatized by trauma, that of fat tissue, especially at the level of the breasts. But also it's possible to appear independently by another totally mechanism, by enzymatic necrosis of the fat tissue. What this means? This enzymatic necrosis of fat tissue, it's an autodigestion. Possible in a very, very special condition, but not rare at all. As we know, we have the gallbladder with the biliary tract, which is drained in the duodenal lumina, where the bile have the purpose to help the digestion of fat substance. Unfortunately, in many people, most people, not in all, but in most people, the pancreas, who also have a duct of excretion, is entering, before entering in the, some are entering directly in the duodenal with a different ostium here. They are protecting from this type of fat necrosis, but this is the exception, not the general rule. But in most situations, this pancreatic duct, the main pancreatic duct, is entering in the duodenum, having a common segment with the biliary tract. If we have an occlusion here at the sphincter of Oddi level, the bile flowing will have a reflux in the pancreatic duct, entering in the pancreas. Bile is very alkaline in his pH. Pancreas is producing the most powerful enzymes in the organism against anything, against proteic substances called proteases, against lipids are called lipases, against any other structure we have the most powerful enzymes able to dissolve these structures are produced by pancreas. But they are produced as proenzyme, not active. And they are designed to become active only when they reach the duodenal lumina in the contact with bile. The bile being the activator for these enzymes. And they are designed to obviously digest everything is in the lumina of the digestive tract, proteins, lipids, minerals, anything. Connective tissue, elastasis, fibroelastasis, all these enzymes are produced by pancreas, not only by pancreas, but the most potent versions of these enzymes are produced here. In this context of obstruction in this very low but common segment of the biliary tract, bile entering the pancreas will activate all these enzymes in the pancreas and will start a process of autodigestion of the pancreas, also known under the name of acute hemorrhagic pancreatitis. It's a very severe condition, very frequently lethal. And part of this process is activation of lipases here in the pancreas, which will start to dissolve by enzymatic necrosis the fat tissue present in the pancreas and eventually in the nearby to the pancreas itself. The result of this enzyme activation and digestion of the adipose tissue inside and nearby the pancreas, it's the breaking of triglycerides. This is the chemical structure of triglyceride, meaning we have a glycerin molecule, which is a 3-alcoholic molecule having 3 carbons, each being in connection with a fatty acid. The enzyme is breaking here the molecule. So liberating the glycerin, which will be absorbed in circulation, and also liberating the fatty acids. Being acids, fatty but acids, they are reacting with nearby present minerals like calcium, resulting from this process salts of calcium with fatty acids. It's called also saponification, this reaction, because it's transforming the fat in soaps. These are the soaps that we are using ordinarily, in fact, resulting from such a process. Obviously, a controlled process. But these salts or soaps of calcium with fatty acids are, from macroscopical point of view, whitish, yellowish area, looking very much similar with wax drops. And this is what we see very characteristically in acute hemorrhagic pancreatitis, the appearance in the pancreas and in the nearby fat tissue of these wax-like drops. And for this reason, just seeing macroscopically for the surgeon, such wax drops when he's opening the abdominal cavity for a very intense abdominal pain generated by the pancreatitis itself, if he is seeing the wax drops, he knows already, even before seeing the pancreas itself, he knows already that the cause for the pain is pancreatitis, which is not a surgical condition. So he will close it back. The patient, he don't have to do anything from surgical point of view and wait for what is happening next. What is happening next? It's death in most situations, or with a proper treatment, which is a very aggressive, consisting in anti-enzymatic perfusions with very, very special substances which are blocking the activation of all these enzymes activated in the pancreas. It's possible eventually to stop the process and to not necessarily heal, but at least prevent the lethality of the case. It's a very, very interesting disease by this mechanism. The main situation when such a thing is happening is because of a gallstone migrating in the biliary tract and remaining blocked here. And this is happening mostly in women because they are by far the most frequently affected by gallstones. But also possible in men, even more frequently after heavy drinking. In heavy drinking moment, when they enter in alcoholic coma even, they very frequently, the persons who experience, men or women, such a thing, they experience vomiting. Vomiting consists in an antiperistaltic contraction of the digestive tract with the disparate try of the organism to remove the excess of alcohol out. But in this contraction, spasmodic antiperistaltic contraction is contracting also the sphincter of Oddi. And if you had a very heavy drink together with a very heavy meal with lipids, like it's happening mostly in Christmas, the presence of lipid in your food, it's stimulating bile to be produced and released in large quantity, and the alcohol is generating the contraction of the Oddi sphincter, and the result will be a heavy reflux of bile in the pancreas, generating acute pancreatitis. This is why this type of accident, little sometimes, it's happening mostly during Christmas period. When, at least in Romania it's the case, we sacrifice pigs, and after that we eat a lot of fat with a lot of alcohol. Here is the necrosis characteristic for tuberculosis, which is like cheese, whitish. We'll discuss about more about it in when we discuss about and tuberculosis. And this is the wax-like droplets, whitish, grayish in color on the surface of the pancreas in an acute pancreatitis. Obviously a little one, because what we see here, it's an autopsic examination of. And here the same wax-like drops present in the fat of epiplon structure of the abdominal cavity. The epiplon is the first tissue to be seen when we open the abdominal cavity. And if we have such wax-like droplets on the surface, we can already know that it's a pancreatitis, and we don't need to enter more deeply to see the pancreas itself. So the surgeon is just opening, it's seeing such a thing, and is closing it back, and it's starting the treatment with perfusion with anti-enzymatic substances. Here is the microscopy of the adipose tissue in the pancreas itself being necrotic after such an enzymatic activation. More detail of this image you will receive in practical lab. This image will be, and the previous one also, images for your practical exam. But you will have all the details in the practical. And this is the final slide for this lecture about a very particular type of necrosis called fibrinoid necrosis. It's called fibrinoid because it looks like fibrin, but it's not fibrin. And it's seen only at microscopic level, so macroscopically we can see nothing at all. And it's a very special form of necrosis seen mostly at the site of immune or autoimmune reaction involving blood vessels, meaning in the wall of vessels in what is called autoimmune arteritis. Like it's the panarteritis or polyarteritis nodosa is such a type of arteritis in which the fibrinoid necrosis is quite pathognomonic, it's quite characteristic, but only seen at microscopic level. Thank you. In this way we finish this first subchapter of metabolic disease, and we'll continue next time with the metabolic diseases themselves. Thank you again.